thank you for this generous introduction. At the outset, let me congratulate ESIC Medical College and Hospitals for organizing this very important and relevant program of deliberating on emergence of resilient healthcare systems in India. And I would also like to express my gratitude for inviting me to be part of this important discourse. And therefore, I would like to just compliment and congratulate Professor Srinivas, the Dean of Medical College, and Dr. Paul, who is the medical superintendent of the institute, and of course, Dr. Sushma Katkuri for organizing and facilitating this important discourse today. We have colleagues, Dr. Praveen Pasudde is there, then we have co-speakers with me in the program today, Dr. Animesh Jain, Dr. Shiv Shekhar Datta, and we also have Dr. Shweta Rajeshwari. All these eminent speakers, participants and delegates for today's programs, luminaries from the field of community medicine and public health. It is indeed a pleasure for me to be part of this important discourse today. And as being mentioned, what I would do is would share some reflections and some of my thoughts in the context of healthcare systems response to COVID-19. But what I felt is I wanted to re-articulate this particular title so that I can be more comprehensive and to the point when I discuss issues in the context of healthcare systems response to COVID-19. What I felt is that I should re-articulate my reflections as leveraging the learnings from COVID-19 pandemic for strengthening health systems in India. And as rightly mentioned by Dr. Sushma in her initial brief remarks, that there's so much that we have learned, and she used the word actually COVID-19 pandemic as a teacher. And in true sense, actually COVID-19 pandemic is a teacher. And we need to learn from that if we really wanted to redesign and recreate our resilient healthcare systems. And therefore, I would mostly focusing on how we can learn from the COVID-19 pandemic issues in the context of strengthening health systems in India, but broadly focusing on healthcare systems response to COVID-19. What I thought and reflected is that I would focus my discourse on four important and critical areas. First is to analyze and decipher the situation using the health systems framework and see that where do we stand from that perspective. The focus of my deliberations mostly would be Indian context, and of course we can refer certain issues in the context of global health systems, but the focus for the talk with a limited time I thought would restrict it to Indian context. But I also felt that in response to the COVID-19 pandemic, it is important to deliberate on issues in the context of the health systems, but simultaneously there are issues beyond health systems also are important, relevant, and can influence our health systems and overall dynamics of disease transmission in the community. And therefore, it is important to briefly deliberate on those issues in relationship with the health systems framework. And of course, whatever I'm going to share is based on my own personal engagement in COVID-19 pandemic. I'm involved in some of the global initiatives in response to the COVID-19 pandemic. I also sit on several Government of India committees which are entrusted with the responsibility of COVID-19 pandemic response. And because currently based and work from home in Nagpur, I am also trying to help the local government here in Nagpur division and Maharashtra, and so much of a learning from that experience. But also it is important to understand, because we all know that this is a novel disease and then the evidence is still emerging, and every fortnight there are the new evidence which are being created. So using that emerging experience and evidence, I would deliberate around these four important parameters that I would consider. Two slides basically, and I'm sure because initially I was reconsidering whether I should mention these two slides or not, but I thought because this is the first talk of the CME program, and therefore it is important to mention the global and Indian scenario. Not in much detail, we all are aware about it, but it is important to begin, and so that we can create a platform for further deliberations. If you look at the total number of cases and deaths, the numbers are presented here in the world and in India. But important is that close to 9% of the total disease burden in the context, global disease burden, I would say, for COVID-19 is harbored in India. And the contrary to that is 5.7% of the total death rates, total deaths, which are we are contributing to the global deaths that are happening. Fertility is lower as compared to global context in India. The case fatality ratio, and of course it's a bit of a variable from every fortnight, but it's 2.2 in the world as compared to 1.4 in India. And we have been in initial days, I would say 3 to 4 months of initial period of the pandemic, where the case fatality ratio was a bit of a fluctuating and relatively high in India. We have been able to manage to keep it as low as possible, but still in certain states it's a bit of a higher. But the overall national average tells us that on that front we are doing pretty well. That's important. But even if you compare with other countries also, this variation in the case fatality across the countries, you would see that quite significantly higher as compared to India. The point I'm saying is at this point in time that we have been successful in containing the pandemic to the best of our ability using our existing health systems, and our national government and state government brought a lot of innovations and initiatives to deal with the situation. Our vaccination program is also being launched now. We have been able to keep the mortality down, but we also need to realize that every life is important, and even the death rate is on lower side, but still we need to see that now how we rigorously implement our vaccination program so that we can prevent the deaths, and the containment strategies, and the COVID safe behavior, and so many other interventions. How do we halt the transmission? Because unfortunately last couple of weeks or so there has been consistent rise in some of the states in India, and that's a matter of concern that we'll have to really revisit how do we handle that in the context of our systems. So setting the context, I would say that almost a year back, in early March or so, we had started, in last year rather, we had started contemplating on the pandemic shaping up, and the later part of March, there was some drastic steps taken by the government of India with a Janata curfew across the country, and then subsequently very serious and stringent lockdown was adopted too. But with the beginning of 2021, the virus is on the consistent decline in India. But as I mentioned, with recent spikes in few states in last couple of weeks or a month or so for that matter, we have conducted three national sero surveys, and there are several sero surveys being conducted by the state government and some academic institutions across the country, which tells us that the herd immunity is getting built. Our vaccination program is now launched, and it was launched on 16th of January, and now 1st of March we upscale that, and there are all kind of efforts being made to upscale the vaccination program so that we can reach to as much as population. And good news is our economy is relatively recovering, because we are not exception to the global economy. We are not exception to what is happening globally. But because of the stringent lockdown, we had challenges, and it has really impacted economy, including employment. And we believe that now opening up of the businesses last few months or so, our economy will continue to recover, and then probably we will try to catch up in the next year. But having said this brief remarks, I would like to mention that our under-resourced health systems has been challenged and stretched by COVID-19 pandemic. And why I'm saying so is that because our health system is really under-resourced, in terms of financial allocations, in terms of human resources, in terms of challenges from supply chain management to leadership and governance. We struggle on several fronts, and that has been challenged and stretched. It is not that the existing health challenges, because they are there, existing health challenges were there, and this pandemic has highlighted those challenges. It is not that pandemic has told us that our investment of resources is limited. We are aware that our investment in healthcare sector has always, particularly public investment, has always been challenged. And there are some new challenges which are discovered and re-emphasized by the COVID-19 pandemic, and it is important to revisit those challenges and, in the right spirit, reanalyze the existing situation in the context of health systems and see that how we can reinvent our health system, reorganize our health systems so that we are better prepared not only to respond the health threats that are posed like COVID-19, but also routinely delivering healthcare services and advancing the agenda of larger universal health coverage. That's the context that we should be looking at. I would like to begin, the further deliberation saying that history is more than the path left by the past. It influences the present and can shape the future. And therefore, we need to realize that COVID-19 will not be the world's last pandemic. Many of us probably even live to see the next one, but we are unlikely to be any more prepared for it if we are really not looking at and seeing how best we respond to current challenges. And therefore, leveraging the learnings from this COVID-19 pandemic for strengthening health systems in India remains critical, because history is more than the path left by the past. Because if we look at in past, in retrospect, it is a historical trail that is there. And why we need to learn from that? Because it can influence our present, but can shape the future also. And in that right spirit, probably we need to look at from these learnings point of view. Dr. Sushma, in her initial remarks, mentioned about this WHO health systems framework. And I thought it is important to mention this framework because I would deliberate in the context of this WHO health systems framework and what are the COVID-19 challenges which have emerged in relationship to that. These are the 6 building blocks: health service delivery, health workforce, health information systems, medical products, vaccines and technologies, health financing, leadership and governance. So these are the 6 building blocks that we need to focus if we wanted to really have a resilient, strong, sustainable health system. With these 6 building blocks in place and ensuring there is equitable access, the coverage is there in the context of universal health coverage that we talk about. We provide quality health care, and I would say beyond quality health care, even a dignified quality health care, and ensuring safety. We would be able to reach our overall goals and outcomes in the context of improved health care, because we would be able to provide healthcare to the population, and that will be an improved healthcare both in the context of the level and equity. Our systems will be responsive because we should be responsive to the needs of the populations and people. It will also ensure the social and financial risk protection that is the hallmark of universal health coverage, and will have an improved efficiency. So we should look at the learnings of COVID-19 pandemic against this particular framework. On the right side, the same 6 building blocks are being presented, but why I have presented another picture here, because at the center you can see there's the people, and we have to look at the people who are there at the center stage, because COVID-19 has reminded us that the role of the community needs to be recognized and responded. And that remains critical because our health systems should be people-centric, and that's an objective I wanted to mention. And from the health systems building blocks point of view, I wanted to re-emphasize, and we all are aware about it, that our national bird is a peacock and not the ostrich. And if we really wanted to fix our problems, we'll have to look around to see where are those problems and where do these problems lie so that we can fix those problems and move further forward. Unless we recognize that there are problems, we'll not be able to advance the agenda of healthcare system strengthening in a right spirit. So that's the context of this health system framework that we have to keep in mind. Now, what kind of health systems do we need? And I put it in a bracket. Obviously, we need a smart health system. And for me, I actually ask a question that what is that smart health system means to me? And then I put these boxes together and put some keywords here. The strong and sturdy health system, the sustainable health system, vibrant health system, robust and resilient, and Dr. Sushma has really wonderfully explained the term resilient. And robust means generally workable, that it should work in any adverse circumstances. Agile, adaptable to the change. Efficient, and in the context of efficient, we should have resource optimizing because we have limited resources. Our resources are scarce, and when we really deliberate on health system, we should really talk in terms of resource optimizing health systems. Of course, it has to be effective. It should be equity promoting and inclusive. And that's a hallmark of our universal health coverage also. It should be empathetic and people centric. And therefore, the point that I mentioned on the last slide, where you can see around those at the center stage and at the front stage of the whole six that health systems framework, you would find people are there. So the people centric is important. It should be responsive to the need of the people. It should be technology driven. The 21st century health system should be technology driven. We need to deliberate how do we use and enhance the technology driven and how we can leverage the technology in advancing the agenda of public health through our health systems. And obviously it has to be culturally sensitive. So this is what to me is the smart health system is all about. And we have to keep in mind if these attributes and characteristics are reflected when we talk about the health system, which is a smarter one. The foremost lesson the pandemic has taught us is that the health systems that is insufficiently resourced and suboptimal in performance in a steady state cannot create a strong and swift surge response when challenged by a public health emergency and health threat that we all experienced in the context of COVID-19. Now let's take one by one of these building blocks to deliberate and see what are the learnings from and what are the situational analysis of this health systems architecture tells us all about. The service delivery component, if we really analyze, it really tells us that and highlighted this COVID-19 pandemic neglect of our public health architecture over decades. Over decades, we have failed and we have neglected our public health architecture, and that has been highlighted this pandemic. One of the critical issues in the context of service delivery that has come to the forefront is our exposed urban primary health care and district hospitals. Apart from some big cities like Mumbai and Delhi, they may have a better urban health infrastructure because they are very rich corporations. But if you look at tier 2 cities or even cities, several state capitals in India, and the municipal corporations and municipalities, they have limited healthcare budget. And the urban primary healthcare infrastructure, I would say, is not up to the mark to respond to the challenges that similar challenges we would confront in future. Similarly, the story of several district hospitals. And although there are systematic, strategic, and conscious efforts to strengthen our district hospitals, but you would realize that in several districts, you would find the situation of district hospitals is not good. A couple of districts in Chhattisgarh a couple of years back reported the first cesarean section was conducted in a district hospital. So after 70 years of independence, the first cesarean section was conducted in a particular district is a matter of really a concern for all of us. Although there is a district hospital strengthening scheme and we have to see that how do we leverage resources from that, but that's a challenge. Health infrastructure is also exposed in terms of safety also. I come from Nagpur, and a couple of years back there was a very unfortunate incident that has happened in nearby district hospital. There was a fire, and that fire has culminated into the unfortunate incidents of deaths of some newborn babies. And so the fire safety, it's a safety audit from the fire perspective, health infrastructure. And this is not an isolated incident. And if you track in last 1 year or a couple of years, you would find that both in public sector and private sector, our health sector, our health infrastructure was exposed. Safety was a matter of concern. Then the another issue that I wanted to mention about is the resources are diverted. Like for example, now COVID-19 pandemic, we had to repurpose our hospital beds both in public sector and private sector, and that was necessity, obviously, but it has also impacted other healthcare services. Now the immediate evidence is emerging, and there are some few papers which are coming up. It has impacted our immunization program. It has impacted, even the lockdown was a major strategy, and we'll not get into the debate which was necessary or not necessary. The question is that because of certain interventions, like lockdown is one of them, but the repurposing of hospital bed, which was necessary, and we had to manage many COVID-19 patients, and we had to create those hospital beds. But it has impacted other surgeries, it has impacted our national programs, including RNTCP, and so evidence is emerging out of that. And so that's also learning for us. How do we, in such emergency situations, ensure that we respond to the emergencies, but also continue to manage and handle our national programs and continue to provide services to the population which are required in the context of other health problems. We have been able to ramp up our testing capacity and COVID beds. This is a brilliant example that when the initial couple of months, you would see that our testing capacity was so restricted. This RT-PCR machines availability, or it was only in few medical schools and few institutions it was available. Now practically in each district that we have scaled up that. This is an example that once we decide, we can scale up our infrastructure. The quality and dignity which I mentioned when I mentioned about the architecture in healthcare remains the hallmark of any health systems. Providing healthcare is critical and important, but providing quality and dignified healthcare is more important. And of course, we generally talk about quality health, but unfortunately, we do not mention and talk about a dignified healthcare. If you see, public sector, the beneficiaries, the clients of the public sector, they come from a humble background. But at times, do we really respect them? Do we really treat them with a dignity is a question that we need to ask. And therefore, whenever we talk about quality, I think dignity as an adjective should be used, and quality should also be associated with appropriately treating people with a great dignified attitude. That's more important. Role of private sector, that we know in a country like India, where we can see role of private sector is very important and critical, and where almost 60 to 70% of the healthcare is being provided in the private sector. And against this background, it is important that we recognize the role of a private sector in providing healthcare. To be precise, almost 70% of the outpatient care is provided by the private sector. It's almost, I think, 58% of the in-service inpatient healthcare is provided by the in the context of service delivery by the private sector. This is the data from NSSO of 17-18 tells us. The NSSO data, when some of my colleagues at PHF have analyzed in the context of human resources for health, and it tells us that almost 65% of the doctors do work in the private sector in country. Almost more than 50%, which 51% precisely, nurses and midwives, they work in the private sector. Overall, human resources for health, almost translates to 61% that they work in the private sector. So against this background, how do we leverage the private sector? And when we talk about strengthening health system is important. And of course, the referral system. Unfortunately, in India, we have a very weak referral system. You would see that even for minor elements and primary healthcare, people are rushing to the medical college hospitals or better district hospitals. Probably even the limited research is also carried out, and the limited models are available to ensure the appropriately designed referral system. And therefore, what happens is that sometimes our tertiary and secondary healthcare setups are burdened even with the primary healthcare. And there are models like, for example, I know Dr. Sharada Iyengar from Udaipur and Earth, and they are doing extraordinary work and developed models of the referral system, and they can be adapted, and we can strengthen our really a referral system. And therefore, when we talk about health systems, this referral system, and even not primary to secondary and secondary to tertiary care, but we also need to reflect the referral between the private sector to the public sector also. At times that we had experience in the context of COVID-19 when the patients are very severe and where the probability of survival was less, and then the patients were literally shifted to the public hospital, and at times they call quote unquote dumped into the public hospital. So all those challenges needs to be looked at. Impact on other services, because we realized that we concentrated our attention to the COVID-19 has diverted our health services for like maternal and child health, for non-communicable diseases, and that has also impacted. And I mentioned about now the papers are also coming up, and evidence is also reflected that how other services, critical services, including immunization services, are impacted, institutional deliveries are impacted. And in the context of service delivery, the other important issue is also the trust deficit. Unfortunately, from the public sector point of view, there is a question that we need to ask ourselves, that why people do not want to go to the public sector. And there is quite a substantial amount of research being also carried out in this particular area, that about the healthcare seeking behavior of the people. And one of the important area that is being highlighted is the trust deficit, the transparency and accountability in our functioning. And as I mentioned about how do we leverage and healthcare technology like for telemedicine or appropriate healthcare technology for diagnostics point of view is needs to be looked at and see that how do we leverage that, and that also remains an important. So we need to recreate. I use the word recreate. Initially I wrote create, but I changed it to we need to recreate systems that can anticipate, avert, attenuate, and abbreviate. The four important things. We need to recreate systems that can anticipate, avert, attenuate, and abbreviate any health threat that, like we experienced COVID-19 pandemic, while, the next sentence is important, while dependably delivering all other needed health services, which includes our immunization, NCD related or other public health programs, with efficiency, equity, and economic prudence. These are the three important hallmarks, and these three E's you must remember: efficiency, equity, and economic prudence. And of course, with continuity, commitment, and compassion. So these three E's and three C's: efficiency, equity, and economic prudence. And continuity, you cannot have a disruption because of COVID-19, disruption in other services. It should be continuously provided with commitment and compassion. Strengthened public sector, therefore, must be the centerpiece of the new health system architecture with enhanced access and public accountability. That's what I wanted to mention after I spoke about the service delivery. Let's move on to the next building block of the this architecture of the health systems framework. We need adroit, motivated, and compassionate health workforce. And when we talk about health workforce, generally we look at that health workforce from three dimensions: size, composition, and distribution. And unfortunately, we in India struggle on all these three dimensions. If you look at the size of the health workforce in India, a total size of Indian health workforce, it is 5.7 million, and out of which uh, approximately 4.19 million are the technical people. You can classify them as health workers, doctors, nurses, pharmacists, public health professionals, our frontline workers, and everybody. And then you have additional 1.47 million people working in the health sector, like for example, the ambulance drivers, administrative staff, sweepers and dietitians and uh, clerical people, receptionists, and so many other people basically. They also work in the health sector. They may not be functioning and they may not be doing health related functions, but they are providing support services. We have 1.1 million allopathic doctors in the country, which actually translates to 20% of our HRH. Our doctor population ratio is around 1 is to 1200. Ideally, it should be 1 is to less than 1000 or so. Unfortunately, our nurses to allopathic doctor ratio somewhere, if you look at, is 1 is to 1.7, which is somehow completely needs to be reversed. And from distribution point of view, it's almost our one-third HRH is taking care of our two-third population in rural areas. Our HRH density, if you look at everybody counted, translates to 33.7 per 10,000 population. But if you talk only about the doctors and nurses and midwives, then it comes down to 25.7 per 10,000 population. And we know that, WHO parameters of 22.8 per 10,000 population, and then 34.5 per 10,000 population, and then the another extreme is 59.4 per 10,000 population. But we are just above that, the baseline category of around 22.8, which is, at the matter of concern rather. We have 40% shortage of obstetricians in the country. That is what the Foxy tells us. We have almost 50% shortage of pediatricians that the Indian Academy of Pediatricians tells us. And if you look at the rural health statistics data of the Government of India, it tells us that 75 to 80% vacancies in rural hospitals, in community health centers of the medical specialists. So this is something which needs to be really reflected upon, and we will have to really see that how do we build on that. Fear and hesitancy is another parameter that this COVID-19 taught us in the context of the health workforce. Initially, there was a reluctance on the part of several people to in the healthcare sector to because of the fear and hesitancy. That's a challenge. Our model is really, as I mentioned to you, is a doctor-dependent model. We will really need to, in 21st century health system, we will have to think that how do we leverage the support from other components of the health workforce, how we can empower our nursing professionals, how we can transform them as nurse practitioners, how we can transform them and empower them to do some of the duties that doctors are performing. So this is the time to revisit our doctor-dependent model. One of the challenge that we have experienced, and illustratively I'm talking about, is the critical care capacity in the country. Like initial phase when there was the felt need of using ventilators for the COVID-19 serious cases management point of view, use of oxygen, and we realized that our nursing professionals lacked in that capacity, and so that was a challenge. Our critical care capacity was completely exposed. And when you talk about health workforce, you cannot talk in isolation about the health professional education. You will have to reconfigure our health professional education to create this adroit, motivated, and compassionate health workforce. We come from a public health background, and COVID-19 pandemic has re-emphasized, re-highlighted the need of a public health cadre. We need people trained in public health to deal with public health emergencies. Public health emergencies must be dealt by the trained public health professionals. Effective use of public health talent in the country is the need of the hour. Unfortunately, we saw some lag in that capacity. We will have to ensure that the public health talent in the country is more effectively and efficiently utilized in responding to the challenges. Better management of medical colleges and other institutions is one of the examples. And of course, I highlighted private sector, and I mentioned to you that there is a significant proportion of health work in the private sector. As I said, when I mentioned about the distribution in public and private sector from the health service delivery point of view, but 61% of our health workforce, that I said to you that we have 5.7 million people who work in the health sector, out of which 61% work in the private sector. 65% of our allopathic doctors work in the private sector. 94% of the Ayush professionals work in the private sector. 89% of the dentists work in the private sector, and 61% of the allied health professionals work in the private sector. And therefore, unless we really focus that how do we leverage private sector, we'll not be able to move further forward. Health information system is one of the building block of our architecture of the health systems framework. I always felt is somehow, unfortunately, is neglected as compared to other building block. And I believe that health information is extremely important and relevant building block. And if we really do not focus on strengthening this health systems information, particularly RHIS and other health systems matrices, we will not move further forward. Data-driven decision making remains a hallmark of any decision making, whether it's a public health decision making, whether it's a management decision making, whether it's a clinical decision making. We need data. And unfortunately, sometimes there is a limited evidence, limited research output from India. And even COVID-19, I think a couple of papers are also published that our contribution looks a bit that data that is being made available. The country like ours, where we have a huge data being generated routinely as a part of our routine health information system, we need to design and develop strategies that we can analyze the data as quickly as possible and put it into in the evidence form in a peer-reviewed platforms. That's important. Science communication is critical to ensure trust among stakeholders. People need scientific information, and if the information that is being communicated with a very rigorous scientific background is acceptable to the stakeholders. Similarly, risk communication is critical to ensure public participation, and both communication channels are critical and important. I would give an example of IDSP for that matter, laboratory data management systems, multiplicity of the templates at ground level. These are small issues, but impact, like one, suppose there is a laboratory which is involved and engaged into RT-PCR testing for that matter. Now, they have ICMR portal. They have to fit the data into the ICMR portal regularly and have a standard format for that purpose. But because they have initially IDSP platform also, which is being operated and used by the state mechanism and connected to NCDC, there's an additional data being fed into the IDSP. Then there is a data request coming from local government and local authorities also. So this multiplicity of systems in the context of providing healthcare information. And then where are the data entry operators? We provided RT-PCR, suppose machines and but where are the people? We need for data, suppose some laboratory is conducting maybe 2,000 or 3,000 tests per day. So putting up the data of 2,000 tests and all the details into the system would require really more number of data entry operators. And so this should be looked at from much more comprehensive purpose and point of view. Therefore, strengthening routine health information systems is important. And we all realize, and we all come from a public health background, and we know that effective surveillance systems to generate accurate, reliable, timely, and actionable data is important. One more issue is about transparency in data sharing. In science, data sharing is extremely important, critical for advancing the science as such. And therefore, there has to be a very clear policy of sharing the data. of transparently sharing the data at all the levels. And that should be made available for all kind of research purposes, and that's how the science will progress. Role of social media in spreading misinformation also highlighted by COVID-19 pandemic. Sometimes, information that is being spread as rumors, as untrue information, creates a lot of problems. And therefore, now the social media, which is, and not only from COVID-19, but many health-related information at times being spread out, which is not reliable, which is not valid, which is not accurate, has created a lot of problems. And country like ours, where everybody has access to now social media, a lot of people have, still have a significant proportion of population which still believes whatever is written in the social media is the correct information. That's a challenge. And of course, I mentioned certain challenges on the ground from the health information point of view. Let's move on to the another important agenda of medical products, vaccines, and technologies. When this pandemic, if we go back exactly a year back or so in March and early April, where March several countries had announced lockdowns and international travel was suspended. Practically, we went into a world which was completely disconnected. And we always had said that the world is a global village. But I would say that from April to up to June, July, 3, 4 months or so, in initial part of this pandemic, we had seen that countries have become planets and independent planets. There was hardly any communication. Of course, I'm not talking about information communication, but the movement of the people and extremely disruption in global supply chains has resulted into, and has taught us that if such situation comes, and then we will have to really see how we can respond to these challenges. Then the self-reliance is important, and this is the government of India has highlighted, and this Atmanirbhar Bharat is one of the important initiatives launched by the government of India to realize and recognize certain areas in the context of the health sector that we will have to really advance the overall agenda of how we can become self-reliant. We are a big country, and we are positioned in such a way that we should be self-reliant from the health sector. Ramp up our annual production of ventilators to 10,000 to nearly 2 lakh. Our annual production of ventilators a year back or so was only 10,000 per year or so. Now we have a production capacity of 2 lakh per year. From limited production of PPEs to 1 million pieces a day we can now manufacture. And it was surprising and shocking that we had to rely on PPEs on other countries. And what is that? Is it a rocket science it would require to prepare the manufacture the PPEs, or it require the science of nuclear science to prepare that? We can do that. Vaccine development is a brilliant example that we have been able to develop the vaccine. And we developed the vaccine from the scratch, which is approved by the regulators, which is produced now in millions and rolled out in vaccine inoculation packets. And we have been able to actually provide vaccine to the other parts of the globe and several countries, and global diplomacy has been brought into. We will have to engage and ensure robust supply chain management, which is needed. Consumables, drugs, shortage is one of the, giving RT-PCR machine is not going to help. As I mentioned about data entry operators, you also need consumables. You also need, and there was a shortage of drugs, consumables, supply, and therefore supply chain management will have to be as a part of the systems. Will have to procurement systems. Arogya Setu as an app for that matter, like for example, repurposing TB and diagnostic COVID. Some of these issues related to medical products, vaccines, and technologies are relevant from the health systems point of view. This is another building block which I believe is very important and critical from the financing point of view, because financial resources are important for creating any resilient, smart, strong, sustainable health system. If you look at our national health accounts, which tells us that the total health expenditure that we have as a percentage of our GDP is around 3.8%, which is far low as compared to other countries. The government of India spends around 1.2% of the GDP on our health. Our out-of-pocket expenses constitutes to around 2.2% of our GDP. Some other resources like insurance and other comes around 0.4%. Our out-of-pocket expenses are close to around 68-69% of our out-of-pocket expenses. And as I mentioned, around 1.1 to 1.2% of our GDP, although our national health policy mentions about 2.5%. But when we will reach that goal, we really do not know. We have to push for that. Because what the government of India spends on health is half of Sri Lanka, fourth of China, and sixth of Thailand. And we also need to realize that although the risk is equal for rich and poor, because the COVID-19 will not differentiate between rich and poor, risk is equal for rich and poor, but the impact is more on poor. If the poor suffers from COVID-19, the impact will be more from the catastrophic expenditure that would result into. So inadequate financing has also contributed to the inadequate urban health infrastructure. The resources are critical and important, and that's important. Of course, one of the positive aspects of COVID-19 is that upfront both central government and state government has taken up the responsibility of providing healthcare, providing free testing, and now the free vaccine is being also provided. So the equity is addressed. Equity is important, and when you deliberate on health system, we should not forget equity component of the health system. And fortunately, COVID-19 has taken care of that. But we will also have to see that the impact of this resource allocation on the resources that would require to provide the healthcare delivery. But path to the UHC therefore is important. Like affordable healthcare, which is taken care of through health financing, is important. And the private sector investment, as we talked about, is critical and important when we really mention about the health financing is concerned. An equitable and efficient health system cannot be developed without adequate public financing. And therefore, we will have to be champions and advocate to push the agenda of health financing in this country. What Dr. Tedros tells us with the WHO DG a couple of months back is that we throw money at an outbreak, and when it's over, we forget about it and do nothing to prevent the next one. This is dangerously short-sighted and frankly difficult to understand. It speaks the frustration because it's not that one-time investment in the health is important. It has to be systematic, strategic, and conscious effort on the part of all national governments to enhance their public spending on the health of the people, because that remains the hallmark of any strengthened health system. Leadership and governance is the last building block, but which is very important. COVID-19 tells us that there has been a proactive central leadership which played role, and there is a coordinated effort at the national and state governments, which was visible in most of the situations. But we also believe that there has to be better coordination mechanism between various technical agencies at both the national level and at the state level. And therefore, and the next important point is also to prioritize and decision making in the context of the One Health. COVID-19 is a brilliant example and a case study of One Health. Animal health, human health, and our planet and environment interacts and can actually result. If we really do not revisit the issues in the context of the One Health, we will not be surprised that there is another pandemic knocking our doors in next few years or so. Our response must be science-based, and our leadership and governance should take care of that. Whole society preparedness response is important. We have to see that engagement of stakeholders is important across the levels, and communities should be at the center stage. Our decentralized governance structure work for outbreak response. We have invoked the Epidemic Diseases Act, and districts are empowered. And that could be a case study that in situations like this, when the districts are empowered to take the decisions and deal with the situation, would help. Engagement of the local influencers and communities are important, where giving messages in the context of COVID, say behavior, or like now the vaccination rollout, their role is important. Ad hoc responses are not an option for the future. has to be a very strategic initiative in that regard. Our strengthening public health institutions, which I emphasized, are relevant and important. The response to be driven by a public health agency that I always felt. You know, we have a national security advisor. You must have heard NSA, Dr. Ajit Doval is our national security advisor. We need national public health advisor. The country like ours needs the National Public Health Advisor and the Office of the National Public Health Advisor to advise highest political leadership in the government to deal with such kind of threats that might emerge in future. And in the context of the health system strengthening, I would also like to emphasize on that the question is not whether we have the knowledge and means to do this. The question is that whether we have intent and willpower to do this. We all know that there is enough evidence to create it to deal with this situation. We have knowledge. We also have resources and means. It's a question as that whether we have the intent and will to respond to the challenges that we are talking about. Last couple of slides that I mentioned to you, that health system strengthening is one aspect, but we also need to look at additional lessons. No, lockdown for that matter needs to be completely investigated in the context of economic losses and health benefits, because we know that any economic impact will have impact on the health, and any impact on the health will have also impact on the economy. Other programs like, for example, Clean Fuel Program. This COVID-19 pandemic also highlighted the multi-sectoral relevance of the public health. Like, for example, social determinants of the health. The initial days when the more number of cases were reported from the Dharavi as one of the largest slums in Asia, and home isolation. Is it possible? Some of us, I know, have visited Dharavi. Where do we, in a small room of 10 by 10 feet, there are people who are living in shifts, overcrowding, housing. How do you do home quarantine or home isolation and those kind of things? We also realized improvement in air quality during the lockdown. Air pollution is one of the threats that we have. 1.6 million premature deaths every year attributed to the air pollution. 49 million disability adjusted life years are attributed to pollution. I live in Delhi, and Delhi is one of the, every year in December, January, February, the worst hit because of the air pollution. One Health is underscored, I mentioned about it. The coronavirus crisis will not be the last pandemic, and attempts to improve human health are doomed without tackling the climate change and animal welfare. It goes in hand. We must realize this. This pandemic has highlighted the intimate links between the health, humans, animals, and planet, and that's the important from the One Health point of view we'll have to see. So this is the last couple of slides that I wanted to mention in the context of leveraging the learning from COVID-19 pandemic for strengthening health systems in India. We will have to revisit our health systems architecture, reanalyze our health challenges in the context of 21st century challenges, re-articulate our public health priorities, and redesign and reconfigure new health system for the 21st century. And then only we will be able to offer health assurance to the people of this country. And to me, what is the health assurance? It has two words, health and assurance. It is the assurance about the health to the people of the country. And what kind of the health? The health they dream, desire, deserve, and demand. And that's the health assurance that we should see health systems become an instrument in advancing the health assurance to the population of this country, which will then help us for the sustainable development. And finally, we will be able to create Swasth Bharat along with Swachh Bharat and Sashakta Bharat. That's how that we should look at from the health systems perspective. Thank you so much for this opportunity provided to me to deliberate on some of my thoughts and reflections in the context of the leveraging the learning from the health systems in advancing this particular agenda. So thank you so much.